Thanks again for those who just joined us to today's webinar. I'm delighted to be sharing this webinar today. So my name is Ibrahim Bou Orm. I'm from the Liverpool School of Tropical Medicine, and this webinar is organized jointly by the Global Health Network in the MENA region, at the Liverpool School of Tropical Medicine, Canadian University, Dubai, ANFNet, and University of Doha for Science and Technology in collaboration with the Eastern Mediterranean Regional Office of the WHO. Um, uh, I'm really delighted to be here with you, everyone. And I think we can, before starting, we just can run through some housekeeping. Next slide, please. So as you can see from the recording notification on the upper right of the screen, this webinar is being recorded and will be shared on the Global Health Network. To translate the speech to subtitles in your chosen language, you can do so using the closed captions function on the Zoom menu and select your language, but please be aware that this is not a kind of a live translation. It's generated by some functions in the system. And due to the high number of participants today, the video and microphones of attendees have been disabled, but you have other ways to communicate with us. So please use the chat function to introduce yourself. And I can see some colleagues already started to introduce themselves. So again, you are most welcome to this webinar. And also, if you have any technical issues, please report them under the chat function. So if you'd like to ask questions to our esteemed panelists and discussant, please put the questions in the Q&A function. Please do so. And also just to tell you that you may do so anonymously. So that's just a few housekeeping notes before we start. Next slide, please. So just running you through the agenda for today and the aim of the webinar. So our webinar today aims to unpack the embedded health inequities across the MENA region, not just by reflecting on them, but also by examining their structural and systemic roots within various forms of fragility, such as conflict, displacement, climate change, economic instability, and political unrest. Through expert-led presentation and a dynamic panel discussion and questions from yourself, the audience, the webinar is expected to eliminate the complex challenges facing health system in our region, while also hopefully showcasing innovative context-driven solution to promote equity and resilience. As you can see from the slide, I'm delighted to be joined by really experts and colleagues from different backgrounds. I'll just mention how they will be presenting. So the sequence of their presentation today, but I'll do a proper introduction whenever I give the floor to each of the esteemed guests and discussants. So today we'll be joined by Professor Trudie Lung from the Global Health Network at the University of Oxford, then followed by Professor Fouad Fouad from the Department of International Public Health at the Liverpool School of Tropical Medicine, and then Dr. Mohannad Al-Nsour, the Executive Director of ANFNet, also will join us with a presentation on climate change and health vulnerabilities in the MENA region. This will be followed by Professor Arash Rashidian, who's the Director of Science and Evidence at the WHO EMRU, and then also followed by Professor Khaled Alsurimi from the University of Doha for Science and Technology in Qatar. And I'll be then delighted to open the floor for the discussion and to take questions from the audience. But most importantly, at the end, our dear professor and colleague, Dr. Awad Mataria from the WHO EMRO will be really giving us some concluding remarks, but also takeaway messages to reflect on while leaving the webinar today. So that's our agenda. And just to give you a quick overview, we have over 200 registration today. So again, thank you so much for attending the webinar and for making this webinar even more interesting, hopefully by contributing to the discussion. And you can tell that we have participants from all over the world. Without any further ado, I'll now hand over to the first presentation, or also opening remarks by Professor Trudie Long. Professor Trudie Long is a professor of global health research and director of the Global Health Network. She brings over 30 years of experience supporting research in low resource setting on everyday poverty-related diseases and disease outbreaks. Trudie spent the first 12 years of her career in the pharmaceutical industry, where she ran clinical trials from phase 1 through to phase 4 in malaria, helminth infections, and diarrheal diseases in Africa, Asia, and South America. Thank you so much, Trudie. It's a pleasure to have you. And please, the floor is yours.
Oh, thank you very much, and welcome everybody to this really exciting webinar today. I'm delighted to speak to you today because we are really moving forward with the Global Health Network in the MENA region. And indeed, I'm delighted to be sharing the screen today with some colleagues who I met in Cairo just a few weeks ago, especially our friends from the East Mediterranean Regional Office of the WHO. We're working really closely with. So what I'm hoping to do is just set the scene really in a much wider lens and talk about where we are with global health research in a global sense, and where I think some of the challenges are. And I hope that just sets the scene a little bit for your discussions today, and then hand back over to you all to take forward. And I really look forward to this truly being quite a workshop-like feel today, and hearing from you all on this, and seeing what we can take forward together. So just move my slides forward. So, we all know what the situation is, that it's really hard to enable research to happen often in places where evidence is missing most. And we still face this really abhorrent gap, really, of most of the research that happens in the world benefits too few a portion of the population. And then where research does happen, it's often in the wrong places, asking the wrong questions in the wrong settings. And we really need to shift that equity and move it really out of just working in very rarefied centres of excellence and silos, and really have equity in who's leading research and who asks the questions and where the research is benefiting people. So with the Global Health Network, we do a lot of work on trying to shift to thinking about where most healthcare is accessed, the most impoverished settings, often in the community. And then if we do bring the ability to do research to most people, that's also a really fantastic vehicle for developing careers and really shifting some of the inequities in healthcare. And so I think a lot of the focus today, whether we're at the WHO and talking about the research ecosystem, or talking to governments. I've got a meeting later today with quite a few senior leaders across this field, and we keep coming back to global health is local health. And I think this is something we should all embrace, really, this awareness that to change health outcomes, we need to do research more, and research needs to happen in places where it's missing. So I'm just going to try and orientate around that a little bit more. And if we look what's happening in the world today, we're facing outbreaks all the time, obviously across Africa and the Middle East region as well, and across to the most vulnerable settings like Bangladesh or Pakistan, Nepal, where we're facing cholera outbreaks all the time. Outbreaks and diseases emerging are part of life in most places. They're seen as being quite a surprise, and everybody's been taken up after COVID. But disease outbreaks happen all the time, and often they happen in the most difficult areas to reach, especially borders. And I think some of the focus is about working better and in partnerships and working between countries, and recognizing that most diseases happen in the most vulnerable places like this, and that, of course, pathogens don't recognize borders. And so working together in a more collaborative way and coordinating where the disease burdens are, that can really help mobilize a response. And I'm just giving the example of Mpox here, which happened in the most vulnerable area on the far east of the Democratic Republic of the Congo. And most of the response happened kind of around the politics, because there's a real issue, of course, with DRC and Rwanda. And we've got the countries that are all close up together. And what happened was science worked actually across this setting, and it was still possible to sequence the genome, get the science out, let science happen, even around all those very, very difficult local politics. Equally, last year I was up in the north of Argentina on the Paraguay border, and there was a real upsurge in the arboviruses and real outbreaks of dengue, and that's where Zika happened in the past. And having all of these happening at once, again, we've got to let science overcome those challenges. And even something as straightforward as WhatsApp could be a really helpful vehicle, just as an example. But I'm just trying to get across this really important concept that we need to let science happen across the politics and work together in a really collaborative way. So why does this work? Well, if we have any disease that needs to be tackled, it doesn't matter if it's something that's been with us as long as mankind, like TB and malaria, nutrition, maternal health outcomes, or an emerging outbreak. We need to be able to tackle the whole ecosystem of health research that's needed. And what we know is that the skills that are needed to tackle those different types of research don't vary, which is the good news. It doesn't matter what disease you're working on, whether it's a long-standing disease of poverty, a disease that's been in the whole of society, or a new outbreak. The skills and the skills and the problems that you face are the same. And so what we're trying to do with the Global Health Network, and really picking this up now in the MENA region, is trying to share skills and abilities across different groups so that these questions can be tackled and people can work locally and run their own research projects across the healthcare system, building in research to tackle these issues. So I think this is really where the world is moving to. It was quite interesting after COVID to look at the funding response that was happening around the world, and everybody was suddenly looking at, well, we need to fund pandemic preparedness, we need to be ready for the next outbreak. This was a lot of the voices and rallying cry from the global north. Clinical trials are the thing to do. We need to really put pandemic preparedness in everywhere. Well, I think what we know is that pandemic preparedness is a bit of an oxymoron, actually. And what is the best thing to do is upskill the workforce to be able to gather evidence, measure what they want to in front of them, whether that's cardiovascular disease, aging populations, TB, whatever is the really pressing diseases locally, upskill the workforce to tackle those diseases and give them the mandate and support to do so, and then everything is in place to respond to an outbreak. And I really think this has traction now, and so it's possible to actually work with that funding that is available and the interest in being we're looking out on global health security, which is the other big buzzword at the moment, and actually really make that work for tackling the everyday diseases that communities face. So I think this concept of having research in every health setting, solving what's there every day, but being able to respond, is a really powerful kind of ethos and framework for lots of these things to be framed around. So we know this works because this is a big study that we did with Wellcome a few years ago, and it's actually layered on with a study we did with WHO before then, and some work we did with WHO TDR a few years ago, where we've asked researchers or healthcare workers as well, what stops you doing research? What are the barriers? And it's really interesting because it doesn't matter where you ask this question around the globe. As you can see, everybody finds the same things difficult. But the good news again for this is it really shows that it doesn't matter what disease people are working on. It's the same skills that are a barrier. And so obviously access to research skills and training is really key. And that's what we're working really hard with the Global Health Network to solve. But really interestingly, the second barrier that comes through is the mandate to do research. And this is really key. And this is where it's really important to work from the ground up and the top down. So to get governments and politicians to understand that it's really worth the time investing in research. There's a really strong return on investment, especially if you work at the base of that pyramid, upskilling your workforce to become scientists and research practitioners themselves, and they can do really pragmatic studies that can answer questions immediately to solve the everyday health challenges. And it's quite easy actually to get the skills to them and make the tools available. But one of the hardest things we need to overcome is the mandate for everybody to be researchers. And we're only going to get out of the top of that pyramid if we really have that mandate across the whole ecosystem for everybody involved in healthcare to be a researcher. So just back to what this means and how we've responded to this before is that what the Global Health Network tries to do is make available the tools and resources and the ability to connect and collaborate. So in MENA, we're really working with groups across the region to try and give people the skills and access to the skills and each other to be able to run all these different sorts of studies. And then within the Global Health Network platform, you've got access to all these tools and resources that are either disease focused or they're connecting up with organizations like CEPI or the EDCTP network, and just trying to create that movement of information from expert organizations to really the frontline healthcare workforce, and connect the workforce with each other. So we have areas that are just working, say, with nurses or with the data scientists or lab scientists, so that they can talk to each other and share their skills and resources. So this is all about mobilizing the ability to share knowledge, tools, and resources so that evidence gaps can be tackled wherever they are. In terms of my challenge today, I was given to tell you where we are with what's happening now and what's happening in the future. There are some really key opportunities that are there right now, and I honestly think this is the most important opportunity we've had for decades. There's a couple of things that have happened. There's the directive, the resolution that came out of the World Health Assembly around clinical trials, which has been translated by the WHO into the Action Plan for Clinical Trials. And then we have a new version of ICH GCP. Now, bringing those two together, there's some really key messages in those around making health research equitable everywhere and building research ecosystems everywhere, which is the points I've just made, making sure that research is designed around the community and using the best data science possible. Now, if we do that well, we can really tackle some of this inequity. If we fail, we'll make the inequity even bigger, because the only groups that will benefit from these really transformational opportunities around data science, particularly, and working from community-led bases, if that only benefits wealthy nations and wealthy diseases, then we've completely lost. And we have to make it globally equitable and everywhere. And so this is an opportunity to seize. And this is really my call out to all of you around, especially the data sciences. And we're talking about AI today, taking the best technology that's available and putting it in the hands of every healthcare worker in every healthcare setting to be able to analyze the data that's in front of them. So this is my last slide. The Global Health Network has been running for about 15 years, and you can see that it operates through equitable partnerships across the globe. We've got over 60 different MOUs with groups around the world, and it's really accelerating in MENA, and we're really excited about that and hope we can work with all of you in a much stronger way. This initiative is also the WHO Collaborating Centre for the Health Sciences Division around this knowledge mobilization and research capacity strengthening. So this is why we're working really closely with EMRO, and we're there as an open partnership for everybody to be part of this community. It's a truly open participatory community where this ownership is across the globe in this way. So really exciting to see how we can build engagement with you all from today. I hope that's just given a flavour of where we see the opportunities. Actually, I really want to place it like that. I think we're on a really strong point with so many new methods and capabilities, especially around data science, that are just there for taking. So it's up to us all to harness them and work together to work across borders to tackle the health burdens where they are, but using this best technology that's out there and making sure it's in everybody's hands and not just the few. So thank you very much for letting me join you today, and I'm looking forward to hearing how you get on. Back to you, Ibrahim, and thank you.
Thank you so much, Trudy. Really, very, very, very powerful messages. And I think what I like personally, online with what I work, is your emphasis on borders. And this is also will allow us to do a nice transition to the next speakers, because in our region, unfortunately, we have borders like more than than in other regions, whether we're talking about power lines within countries, or even sometimes trapped population within borders. So thanks so much again, and thank you for highlighting also the need to do this paradigm shift to strengthening local ecosystems for research. So now, given this really very insightful introduction from Professor Lang, it's my pleasure to introduce the next speaker, Professor Fouad Fouad, who is a professor of social sciences and global health at the Department of International Public Health at the Liverpool School of Tropical Medicine. And Fouad has almost 30 years of experience in research, programming, and global health leadership across academia, NGOs, and government institutions. His research focuses on migration and health, with a particular emphasis on forced displacement, health systems in crisis settings, and multidisciplinary approaches to humanitarian challenges. Thanks so much for joining us, Fouad, and the floor is yours now. Thanks.
Well, thank you, Ibrahim, and thank you, everyone. Thank you for organizers for inviting me. And I pray now to have like a sort of a good internet. I'm doing my presentation from a border area in Lebanon, so in the small village there. So the connection is, I get a message every now and then that it's unstable connection. So I hope my luck will be good for 10 minutes only to give my presentation, and then we'll see how to manage with that. Do you hear me well?
Yes, we do.
Okay, so I may remove my camera for now, just like to be sure that it's okay. I guess there's an echo, or it's fine.
Not to us, maybe just for
okay.
you.
Okay, okay, that's good. Next slide, please. So as mentioned by Trudie, and thank you for this setting the scene. So it's really important to look into the issue of health inequity, from different perspectives. And of course, when talking about MENA region, we're talking about, some of the world most protracted conflict that now in our world. This is really sadly to say that, and to, I know people now from EMRO colleagues here, they know even better than me that how difficult when talking about, conflict, political instability, the issue of migration, mobility, and as Ibrahim mentioned, that the issue of this fluidity in border, when talking about people moving between borders in such a sort of a massive numbers sometimes, but it's not only the international borders, but also within the international border, they're crossing those IDPs that crossing the what's called now a sort of power border between different power controlled entities, and that create another challenge when talking about health services and the health equity for health services. So I'll go quickly through some sort of painful fact. I would say that here, see the map here of MENA region. It's part of MENA region, and see how many orange dots here mentioning about armed conflict, and some of them are very protracted. And when talking about 40 million that required urgent humanitarian aid in MENA region, people move massively as a sort of forced displaced, 22 million of people moving in the region, either as refugees or as IDPs. I have like here a list of some examples from the region when talking about Syria, the huge number of almost like a 14 million now of IDPs and refugees everywhere. You know, I mean, according to UNHCR, Syrians or Syrian refugees are now Syrian refugees exist in 132 countries all around the world, and with very few return after the new political change in Syria. Everyone, you know, I'm sure every one of the audience engage in that sort of this painful also news from Gaza. 1.9 IDPs out of 2.2, so it's a huge number. More than 60% of housing destroyed, and the health system almost collapsed, if I should say it's collapsed under the bombing and siege and the sort of a massive attacks on facilities. The same in Yemen when talking about, you know, almost 4.5 million displaced and many in highly need. In Sudan, I can say the forgotten crisis now from the news when you know more than 12 million displaced and almost 50% of population are in need for humanitarian aid. Next slide, please. So we're talking about a huge number of people that are in needs and in very dire situation of destruction, disease, and even for a basic needs like shelter and water. So that you know take us to the issue of health equity and you know how we're thinking about health equity or inequities, you know, in an area like MENA region that's affected deeply by destroyed infrastructure, including hospitals, electricity, supply chain, and so on, of the health work exodus. So many, you know, from Syria, Gaza, Lebanon, you know, Sudan, left, you know, many health workers left their countries due to insecurity and tough living conditions. Also fragmented governance, you know. Within the government itself, this is the situation in Syria, where are fragmented into three power-controlled areas, and the same, you know, when talking about situation in Gaza between, you know, in Palestine between Gaza and Palestinian Authority. So there is a sort of a fragmentation in terms of governance and in terms of respond to such a sort of needs. There's a restriction in access for the humanitarian aid and siege conditions, and we know this news in Gaza about that sort of the long convey of aid that stuck and on the border, and you know, and not allowed to go in, and of course overall the issue of a chronic unfunding and relying on sort of short-term aid, given that we are at the same time in very protracted crises all around the region. Next slide, please. So what are the main health challenges that faced by people on the move in MENA region? As you know all know, we're talking about limited access to essential health services, you know, because of overcrowding or people are in informal settlements. As you know, in many countries in MENA region and other countries, they don't have the right policy for, or shifting from the policy of being in camp into people that are living with the host communities. In Lebanon, more than 1,500 settlements are informal. I mean, they have no camps, no clear structure for this. The issue of legality is very important issue as a health challenge for a displaced population to get access to health services. The issue of sometimes the issue of language barriers, cultural barriers, and I would say, as Trudie mentioned, two issues, border and politics, that they are still major issue when talking about access to health services for displaced population and people on the move. And maybe you notice that I sometimes use that term as a people on the move to go beyond the issue of refugees, that they could have a system by UNHCR, or IDPs, that even more tricky, because when talking about people that crossing they don't cross the international border, but they cross the power border, that they are also stuck in the limbo of the definition and how to receive their services. And also people that move without being defined as either refugee or IDPs. And they could be stateless, but they could be even unregistered, displaced population. So limited access to health services, the issue of malnutrition and food security raised up quickly in the last decade, when talking about, for example, in Yemen, over 17 million food insecure, and 1 million are of children face severe acute malnutrition, let alone talking about the Gaza, which is now inaccessible. Food is inaccessible. People are dying, literally, when they approach, the humanitarian aid point to receive, food and basic needs. So this is an unacceptable, actually, situation. 1 out of 3 children in Gaza severely malnourished now. The issue of infectious diseases and public health crisis, for example, the decline, the drop in routine vaccination in Sudan from 90% in 22 to less than 50% in 25. Maternal reproductive health gaps for example, in Syrian refugee women in Lebanon, they always report delayed or unaffordable maternal services, and especially those who are in remote areas or those who are with high risk pregnancy. The ignored problem, usually in the humanitarian aid, the issue of NCDs and mental health. I would go next, please. So the issue of inequity and gender, as you know, this is a major issue, and especially in MENA region, the inequity deepened by pre-existing gender inequities affected mainly women and girls, marginalized group. But even, I would say, I'd add, as in the last paper published, that even young people, between the age of 15 and 25, that are also, because there's no clear direct program that they receive, they say they have this problem. The issue of, for example, some examples from Gaza of, more than 600,000 pregnant women lacked access to health. Same in Sudan, 4.2 million women of reproductive, face extreme barriers to maternal services. Next, please. I'm mentioning quickly to the issue. I'll give me 2 minutes, not 1. The issue of data gaps. Also, there's a severe information gap, or because of poor tracking of population need, fragmented data, which is a major issue, limited disaggregation by gender, age, disability, and displaced population. And we see that in many national systems, they don't have a data about displaced population. And we have an example from Syria, Lebanon, and Gaza. Last one, I guess, please. Next slide. So why this matter? Because we're talking about, how to prioritize services if we don't have service, good data, disease outbreak that, we see it in the cholera and measles, and the funding flow, and that could also help in evaluating program. Next, please. So how international actors help? We have examples from, the great support sometimes from UN agencies, but also with a lot of barriers to have these organizations function well. That's the same in different countries in MENA region. Next, please. Well, how to help, so by doing some sort of protection, advocacy. This is run by different NGOs in the region. Some organizations have like some sort of specific program, like a war child in working on mental health in different services, and the issue of working on local empowerment and system strengthening. Next, I guess that was the last one. And thank you very much. Sorry for this 2 minutes more.
No worries. I mean, they are definitely.
And I should say I'm happy that the internet went well. Thank you.
Yeah, we were lucky as well to hear your presentation without interruption, Professor Fouad. So thanks so much. And really,
Thank you.
as always, what we take from your presentation is always challenging definitions, because as you said, sometimes these definitions are by themselves, whether defining refugees and so on, are leading to inequities by themselves from the early beginning of defining a specific population. And also thanks for flagging really the conflict and forced displacement determinants of inequities in our region, and going into different aspects of it. So thanks again. So now I'll be kind of also moving to yet another interesting presentation from a perspective of civil society working in the region. So it's my pleasure to welcome Dr. Mohannad Al-Nsour, who's the Executive Director of the Eastern Mediterranean Public Health Network, ENFNET, based in Jordan. And he has taken on a vital role in global health security as the newly elected chair of the Global Outbreak Alert and Response Network, GORN steering committee. His election comes after 2 years of service as deputy chair, during which he reinforced the mission to protect lives during crisis. Dr. Al-Nsour brings decades of experience in public health practice and emergency response from the region, and he will be highlighting yet another complexity when we look at health inequity in our region. Dr. Nsour, thanks again for joining, and the floor is yours.
Thank you very much, Dr. Ibrahim, and thank you for organizing for this kind invitation. It's my pleasure to be part of this very important webinar for today. So my presentation is going to be about the climate change, and this is really very important topic. And a few decades before, we were thinking that climate change is our region, the Mediterranean region, is away from the climate changes. And however, we see now the magnitude of the problem is growing in our region, and we see different things that we have. As Dr. said, Dr. Fouad said, maybe the main challenge in the region is the emergency, but however, the climate change affecting emergency situation, as well as stable countries that do not have any type of emergencies. So this is very important, and we believe that this is something that it has to come over to avoid this matter. So in the Eastern Mediterranean in general is expressing climate change and alarming response. According to World Bank last report, and where the Middle East and North Africa region as among the most vulnerable region among over the world and to climate change. These impacts, are expected to result in acute scarcity of water, humidity, and undermining the sustainability of agriculture, resources, and ecosystems. Projections, according to World Health, World Bank report indicates that projection indicate that the climate change could drive the estimates of almost 130 million people into poverty by 2030. Natural disasters, which are becoming more frequent and intense in our region. And again, particularly smallholder farmers and women and vulnerable groups, as we will see in the presentation. The construction sector is also expected to be heavily impacted by heat stress, potentially losing up almost 40% of total working hours by 2030 due to the rising temperatures, especially affecting migrants and low-income countries. This is just, to show the burden, the economic burden of the climate changes from not only from human being, also, which is very important to look at this from the economic burden and how it can be affected the countries. Now moving to the what we are facing in our region. So we have almost three pillars for that. It's rapid temperature increase, and we see summer temperature going to exceed 50s, and we see this in different countries now in the region, and with the projection showing continuous increase of almost 4 to 5 by 2000. And we remember last year, what happened during Hajj time, and I think many of the countries are affected with the temperature, and many of the evidences that we are witnessing this such increase in different areas in the region. Water scarcity, and here again, to the latest reports, Jordan, Iraq are more affected countries by extreme water stress, which affects the agriculture and affects all the epidemiological profile of these countries and disease burdens across the region. So extreme weather, and here, it's very important matter about, how we can, extreme weather and how it's affected, and how it's growing by almost 30% in the past 2 or 3 decades, creates multiple environmental health. And we have many examples about extreme weather in the region. So again, what else we see land degradation, and this is very now affected by North Africa, example, Algeria, Tunisia, Morocco, and we see this, how highly affected these countries and how it's growing. So water stress is always, an issue in our region. The stress, especially, comes now under two main factors, the scarcity of water by itself, and the sources of water are under political, sometimes a geopolitical situation in many countries. And again, Iraq, unfortunately, are losing, almost 40% of their, water sources due to the current situation for both rivers there. So nutritional outcomes, and I think, this is very important, and we see the drought everywhere in the region, and mainly, but it's North Africa, Mauritania now. We are talking about, these parts of the world, Somalia, of course, and other countries in the region. So the magnitude of nutritional outcomes is growing and affects, different countries in the region. Back to, we, conducted some sort of survey among, using Delphi study, from the region, where we got feedback from 45 experts in Eastern Mediterranean region with experience with the climate change and has participated in the first round. And the results of this survey has shown, the major health impact is related to the extreme heats, water scarcity, air pollution, and these are the major pillar in our, as we said, before, in our region and beyond. I like, to also, to sometimes the waterborne diseases is growing in our region, and this is very important things. And we start seeing, different examples. For example, from the global examples, that in previous years we had only 16 countries affected by cholera. Nowadays we have more than 32 countries in the region. We witnessed countries were free from cholera, but unfortunately in the past few years, like Lebanon, for example, we start, seeing more cholera outbreak. And of course, the biggest outbreak over the world and in the history is in Yemen. So these are things that are dependent on the water scarcity and the quality of water at the same time. Dust, when we are talking about air pollution, it's not just for the dust is coming now with the Gulf to the Gulf countries, and that's why we see increasing of different diseases related to the respiratory infection, cardiovascular diseases, and other illnesses in different countries. Vector-borne disease, and here it's very important. And countries where they were free from vector-borne disease or it's not reported, now we see, countries that they are start reporting such diseases, and other countries we see the significant increase in these countries about this. And we see, the leishmaniasis, the cutaneous leishmaniasis, visceral leishmaniasis are growing in different countries. And we see malaria in countries that they never reported that, but also, we start seeing, the dengue fever even in Gulf countries like Saudi Arabia, Kuwait, United Arab Emirates. So these are new changes that we start seeing in different countries. Food insecurity, I think Dr. Fouad, presented this very well, and always we have now what we witness in Gaza, unfortunately, is really a shame to witness this, but it's a huge, malnutrition things. And again, in Somalia and in different countries in the region. Mental health, and always, there is climate disaster, displacement, and livelihood loss, causing anxiety, depression, and trauma, as we know. So vulnerable populations, as we know, the almost the first, category that we have to give more attention to is children, elderly, and women. These really the group that we always giving more opportunities because they are vulnerable, and it's very difficult sometimes to them to cope with the extreme heat, malnutrition, new diseases, especially when the women pregnancy, and traditional communities, etc. So these are one, and again, displacement population, immigration, conflict affected areas that we are, and low income countries, they cannot, allocate the money, and they cannot, consider the climate changes on the top of their priorities due to the low income or, the shortage of fund and limitation of the fund issues. Now, what we have to do, and how we can ensure fairness of climate change. So we start recently in the region, not, maybe the last decades, to believe more that climate change is affecting our region, and we are not beyond. And this is not something only for Western countries. We are affected more than any time before Africa and Eastern Mediterranean region. So what we need to do, community involvement. And here I have to be very frank and to say that still we are very, very new about the concepts of, community involvements within the climate health interventions. We need to do more about this very important area, feedback loops, and to create mechanisms for community members to voice concerns, transparent communication, and this is something that Always we call for more transparency, and we have to respect different cultures, different sensitivities of the communities, and to make sure that we adopt, methods that culturally fit and appropriate to our region and to our countries.
Dr. Sur, would you please just take us through the wrap-up notes, because
Okay.
thank you so much.
Thank you very much. So if to jump, because I maybe I would like to say that climate change is in our world is no longer a peripheral environmental issue. It has evolved into a full crisis that threats the region core human security. As these changes continue to unfold, urgent action for governments and from governments and the international community is imperative to implement sustainable, forward-looking policies before consequences become irreversible. Thank you very much, and sorry for the technical problem that I have used. Sorry for that. Thank you.
No worries at all, and thank you so much for highlighting really yet another complexity and the intersection between different drivers of health inequities in our region. And as you clearly mentioned, Dr. Nsour, kind of sometimes these climate stressors are even, if I may say, localized or higher in settings affected by yet other problems, or not problems, other factors such as forced displacement and so on. So thanks so much. Now I'll just, for the sake of time, I'll jump straight ahead to introduce the next speaker, who is Professor Arash Rashidian, who's the Director of Science, Information and Dissemination. Apologies, I mentioned something different, completely different when I introduced her the first time at the WHO Regional Office for the Eastern Mediterranean region. Since 2015, he has led the WHO Regional Agenda on Evidence-Informed Policymaking, Health Information System, Digital Health, Health Promotion and Governance, and Knowledge Sharing. His career in health policy research and health system development spans over 25 years and several countries. Dr. Rashidian, please, the floor is yours. Thanks.
Hi, Ibrahim. Hi, everyone. Many thanks indeed for the invitation and for the opportunity. And no worries, I mean, the name of departments and responsibility in WHO are always complex and subject to change. So, but you refer to it correctly in terms of context. Okay, so in terms of what I've been asked to talk is more of a sort of focus on what academic institution can do more in support of addressing health securities. And in a way, in the title, based on the discussions I had with the colleagues, I mean, my three messages are actually in the title: evidence on priorities, effective intervention, and policy impact. And my goal is to elaborate further on these, and then also to refer to some of the activities that WHO is doing in these areas. So I'm trying to move forward. Somehow it's not moving. Now I found the grasp of it. So as I mentioned, that's the outline of my talk, the areas that I'm going to talk about. So I don't take too much time on this. So I start with a major report that WHO EMRO released in 2023. I mean, the social determinants of health, the Commission report, Build Back Better. I mean, it has a lot of message in terms of the inequities that exist in the region, between countries, within countries, but also certain big picture. And the graph that you have on the right side is actually showing that quite interestingly between countries as well. So even at the levels of similar income levels for countries, the outcomes could be substantially different in terms of life expectancy. So in a way, we could do much better. So it's not just that some countries are doing better because they have more resources, but also countries that have similar resources could do substantially different. So that picture we are aware of, and we know that it exists. There are other important reports that I'm also referring to. I mean, we published two progress reports on progress on health-related social development goals, and showing that what has happened in terms of the countries, and also a couple of reports on what we call the regional health profiles, which I will refer to some of the results of that shortly. But in the progress report on the sustainable development goals, I mean, you can see the summary points on the right-hand side of my slides. Progress in most of the indicators is either stalled or doesn't exist, or we are not aware because data systems are not good enough to be able to measure it and report it across the region. Obviously, again, variation exists between the countries, but at the regional level, I mean, it would be difficult to see all those areas and because of lack of data. And when we see it, the picture often is not very positive. Climate change, I mean, my dear friend and colleague, Mohannad referred to it. I mean, sort of these are the picture, this affects, is a determinant, but it affects. And usually when something goes wrong, areas that have low resources within countries as well, compared to the rest of the country, they are more affected by outcomes from the climate change. Another key factor, so is what we call the zero-dose children. That is, it has a technical definition, which you can see it on the slide. But apart from the technical definition, I mean, just the normal definition for this would be that children that have not received any vaccine, basically, they have not been part of the national vaccination program. And the number is quite big. A big proportion of global number is there. Our objective has been to reduce these to half over the period of the time during the sort of SDG objective time. And it has been rising in the last few years. So, I mean, we will be updating this figure shortly, I mean, in terms of what's happening in the last couple of years. But at the same time, what we know is that we are not on track. And this is becoming one of the major areas of work for WHO as well, so working with countries. But most of it, again, happening in areas that are sort of inequity exists in other fronts. Now the vaccination issue also becomes a challenge, further challenge. When it comes to research studies, certain research processes are more helpful in understanding equity concern. For example, long-term prospective cohort studies. The capacity in the region is expanding, so that's a good point, which I show in this graph. But again, when we've analyzed countries and we've analyzed, I mean, the different institutions, this is also not giving a good picture of what's happening. And that's an area that further investment is needed in the countries and indeed in academic institutions to do better on that front. Okay, coming on the key messages, which I repeat now and then try to elaborate further. I mean, for academics, by that I mean institutions, individuals, I mean people who are, I'm proud of my academic background for many years doing research on health system, including on equity related issues. So generating evidence of inequities. It's not just showing that there is a difference, but trying to show the covariates, how they are linking with each other. Often the bigger picture defies the sort of the main message. The bigger picture, for example, we know there is gender inequity in countries, in many countries, for many health outcomes, okay? But gender inequity is not distributed across the whole society equally. So when you go, then you link the gender equity with socioeconomic indicator, then you realize, I mean, the gender challenges perhaps are existing in certain parts of the society, but not the other. Geography, the same, and other factors then bring forward. So generating evidence is not just the big picture issue, it's quantifying, showing it, and showing the covariates that affect that. A big task that usually academics find it difficult is that making sure that evidence becomes part of the policy decision, part of the agenda, informing that requires engaging with academics, giving consultation, developing evidence spirits, engaging in development of policy brief. And then after that, what usually policymakers need is that to identify effective interventions that are good for the outcome, but they are also effective to address equity consideration. And that's not a simple solution. Many solutions that we have through the health services that we provide, which are helpful in improving outcomes, they are not necessarily addressing equity issues. Why? Again, usually health systems are better used by people who have more resources, and they are usually designed in a way that they are more accessible to people who have more resources. We heard about, I mean, the sort of people in the migration, displacements, etc., consideration, refugees, but it applies also in different elements of the society itself. And then evaluating policies. That's a key role. Again, it's difficult to do in most contexts, but it's a major role to be done. So elaborating on some of those, I'm referring to a study several years ago. I had the honor of supervising one of my former PhD students, who is now a faculty, a very strong faculty in one of the universities in Iran. So we used the two national surveys to look at inequity in terms of child mortality in the country. Okay, fine. what we observed, so we know, for example, certain provinces in Iran, outcomes are not as good as the other provinces. That picture has been known. But we looked at the within province inequity, within those province inequity in terms of child mortality. The picture, what it showed was that the importance of looking into the details. Let's say, for example, Mazandaran is one of the provinces in Iran. So one province in Iran that has better outcome in terms of child mortality, but it had also one of the highest inequalities within the province between different sectors of the society in terms of socioeconomic situation. So if you look at the full picture, the higher level picture in terms of the where to act, you go to the provinces that they show the most problems in terms of inequity compared to the others. So they have lower outcomes the high mortality here in this case compared to the other provinces. But if you want to address within those societies, you need to make sure that you are affecting the societies that are directly affected, not the bigger picture. So the details matter a lot in understanding in provision of evidence, but also for targeting for policymakers. And that also affects what interventions work better here and there. So this slide I've used a lot in discussion with policymakers, and also with when we talk about how academics can support. So when policymakers have questions, usually they look at what's the problem. So here we address it related to equity-related issues. What are effective and safe interventions? Which one of them are cost-effective, but more importantly for policymakers, are they affordable? Can we manage it? And which ones we can sustain? So to be able to identify this, then the data becomes extremely important, and sort of data from national data for interpreting research from others, but also being able to analyze research studies that are not necessarily from the context, but making them relevant to that context. These are, again, the areas that can guide sort of policymaker process. And naturally, as I mentioned, so then if as an academic institution, you are involved in doing those, you should be able to also help to develop tools that help decision-making, policy briefs, guidance, etc. We did a survey of 18 countries of the region in 23, asking about the capacity for national guideline development. 80% of the countries mentioned they lack technical capacity for or elementary required for evidence-based guideline development. They also highlighted several other challenges. Many of them are structural within the health system, within ministries of health, etc. Summarizing all together, technical capacity, whose role is that to provide that capacity? Academic institution, by training people who are strong, but also by providing advice to policymakers, to ministries of health, financial institutions. But look at the others: limited evidence research, local data. So these are, again, by looking at that title, how to address those become the role of academia. But we need to also be aware that whatever academic institutions do, whatever academics do, is not necessarily a good solution. Good science is the important thing. We learned that during the COVID pandemic. As WHO, we were observing clinical studies being conducted in COVID sort of throughout the process. And there were many studies that had been planned poorly, many studies that had been designed poorly, many studies that had been implemented not completely. And then there were academics who make sort of erroneous conclusions based on the studies that were not really good. So governing and also having a science ecosystem that work to guide, to prioritize, and also to ensure this academic side, the science part also does the job properly. That's really important. So in a way, as academic institutions often, I'm talking here myself as an academic, not from the WHO side, we usually blame policymakers for not being receptive, or perhaps the media not understanding. But there is a bigger role also to be played by the academic institutions to make sure the role that is supposed to be done is done properly in a responsive way and in an effective way. What are areas of WHO work in this area?
Apologies, Dr. Arash Rashidian. Just if you can take us to some concluding remarks, that's because
I'm going. Yeah.
Yes, please.
I know. I started very late, so I go very quickly now. So data system, enhancing data systems, evidence-informed policymaking processes going forward. There are several tools. Sort of bringing that forward. There is a network of institutions for evidence-informed policymaking. Several work has been done through that network with different countries during the COVID in particular, and key lessons for those are really important. So I will leave these to you. Capacity building in terms of research processes and guidance on those, national research priority setting with countries. And then obviously there is a global equity network and inequality monitor website. That's really important. I leave this to you. It has the opportunities for capacity building, generates a national and global reports on health equity, and a lot of textbooks that can be a guide on how to enhance capacity and conduct equity analysis. I'll stop here. Many thanks, Ibrahim.
Oh, thank you so much, Trudie, and apologies for kind of rushing speakers, because I mean I would like to allow a bit of time for Q&As. And thanks again. And my key message from your presentation is really the importance of the details, right? Especially for people like us trained in epidemiology, we know that sometimes looking at averages and big estimates is some unfortunately hide a lot of inequities. And for that, the institutional capacity that you mentioned at local settings is important to kind of identify these numbers and these facts. Thanks again for the presentation. Now, last but not least, I would like to invite Professor Khaled Alsurimi from the University of Doha for Science and Technology in Qatar. He's a professor of health care management and public health and the head of department there. And Professor Alsurimi earned his PhD in public health and health system management from LSTM in the UK. And throughout his extensive academic journey spanning over 20 years of experiences in public health and health policy and management, he has made a significant contribution to the field over the course of his career. Professor Alsurimi, thanks again for joining us. The floor is yours for the presentation. Thank you.
Thank you, Fouad. Just while my presentation is downloading, I would like to thank you all for the opportunity and to be part of this webinar. And I'm glad that I'm in a right position now after my colleague present the context of my presentation. So I hope my presentation will be quick and to put what has been said in the context of how we can build our resilience and equitable health system. Okay, thank you very much again. And as you know from the title of my presentation, I've been asked to share with you some thoughts about the building resilience and equitable health system, innovation policy, and regional solutions. So as I said, I'm in a good position that most of the topic that I might theoretically emphasize has been addressed in terms of tackling the inequities in conflict and humanitarian settings by Dr. Fouad, and then by Dr. Al-Nsour, climate change in healthcare, and nicely by the Dr. from WHO about the role of academics. So this has put me in a position that I will not have a problem with exceeding some topics. So please go to the next. Yeah, my agenda actually is go through 4 questions, which is why this topic, equity versus resilience matters. Then I'm gonna share with you what you mean by resilience and equity in a nutshell. And then why is health inequity deeply rooted in our regions? And I think this has been addressed partially by my previous colleagues. And then what can be done at policy level, at technical level as well. Next, please. So as you can see here, equity and resilience matter. It's not just a matter of, we look at it as a point that we like to talk about it academically or theoretically. No, the equity has become like a result of actions. As you can see in our regions, we have ongoing conflicts. We have war in most of the MENA regions. So equity now is not only just a choice to address it. It's like a result of many problems. You see this happening in Palestine, Gaza Strip, Yemen, Sudan, Syria, as mentioned before. So equity for us in our context is a different things, because it's become a result of something wrong happening. It's not only because we need to give equitable services. We are not now an optional position that to address equity in a way as part of the core value or healthcare system. It's become a must to be addressed. Next things is because the negative impact of a burden of climate change, as addressed by my colleague, that is really affecting our fragile health systems. Most of the systems in our region are fragile most of them, if you just take out the GCC countries or the Gulf Council states, which is somehow they are high-income country, but it is still fragile with the way the system is really built in terms of the workforce. When I say fragile, it's not only fragile because it's affected by the problems like war. Even if you talk health system in Gulf, I work in Qatar, 80% or more, 90% of the health workforce are expats. I saw this fragile system. For any reasons might happen, this expat might leave the country and the system may collapse. Also, equity and resilience is a big issue for us because of one reason, as you can know, and it was like for me a weekend lesson learned from COVID-19. When you found COVID-19 give us, it is really a core issues in terms of inequity become a political issues. And we see that COVID as a matter of disease affected people and the world as a pandemic, but in an equitable way. Some countries were able to adapt, to be resilient, to accommodate the problem. Some countries, it had a lot of problem and issues in that at the beginning. Even after vaccination being discovered, we face equity problems in terms who will receive the vaccine, etc. So these kind of tell us why equity and resilience is a key issues for health system in our region. Go next, please. Now, because we want to do action about it. So when I share with you this CDC framework in terms of public health function services, as you know, there is a global functions called 10 public health functions. Before COVID, what was in the core was not the equity. It was the research and evidence and data. But unfortunately, when we hit by COVID, we found it's not like evidence. We know the evidence somehow, but what was equity is a big issue because even if you have treatments, you cannot give it to everyone. You have to be able to afford the vaccine price, etc. So they reshape the framework, and instead of having the research in the core, they replace with equity. So now equity is really a core for all the three main functions of public health: assessment side, policy development, and even assurance and delivery. And so if you look at these, there are 10 functions, but all of them group around our three main functions. But the message I'm trying to see here, this even framework lasts for us for years, but after COVID, equity became the core. So without addressing equity while you are doing assessment health status, collecting the data, as you know, unfortunately, when you do a survey, for example, as my colleague presented from Iran, we found that sometimes because in the region, most population live in rural areas, and having them in part of the survey is not that easy. Most of our health workforce concentrated in the urban area. So by default, we end having inequity in terms of many things. So unless equity became in our mindsets in the policymakers, because for me, equity is more political terms. It's about fairness, it's about justice. And even with us as a healthcare provider or as academician, then when you do anything, equity should be a part of our thinking. So this is one level of how we view equity to build equitable system, a resilient system from public health perspective. Next, please. Now, in terms of those who are working in the surface level, as you can see, I'm not sure most of you are following what call it aims of the system, moving from triple aim, quadruple aims. Now we are quintuple aim. What does it mean? About 10 years back or less, most of the system around the globe, they work here about three main aims, which is patient experience, population health, public health, and reducing cost, because these were the main aim for any system. And after COVID, they found that the core team well-being was under risk because we lost them. They were in the front line, and unfortunately, they pay the price. Then the ad was called quadruple. That means we need to protect staff as well-being, because otherwise, how you can assure good patient experience by building out without having protected health workers? And then after that, we found that, oh, this is not enough. We have to look at health equity as well. So now the good things now as equity became like one of the aim at the system level. And I'm happy that this has became like advocacy towards put equity as a main goals. Yes, we care about safety, about efficiency, about patient-centered care. All these are important, but equity is become like a core for anything else. So now I'm proposing to you the previous one about public health functions, and this is about the health services and the level of delivery. So equity should be among our aims, not only as a matter of anything else. Next, please. So now we go to our core business, which is resilient and equity. And I'm not gonna actually give the things in terms of the definition. We know, all of us, and equity is about fair and justice. And I would emphasize equity is a political definition. Unless we advocate in the political agenda about equity, we will be not heard well. So it's about justice in healthcare. It's about inclusive access to care for all. I know it's not that easy, but it should be in our action, in our advocacy, in our wherever you go. And then the resilience, it becomes like, to what extent we in any health system able to withstand shocks. In our region, there is a lot of shocks. Climate change is a shock. COVID is a shock. War is a shock. All these are shocks, and adapt to the new situation. So situation is changing constantly. So then we cannot talk about resilience without equity. So when we talk about our system is resilient, if there is no strong foundation for building equitable system, resilience will remain superficial. So equity and resilience, they go back to back, but equity is a basic for helping resilient system or resilient healthcare. Next, please. So I like this when I present in the equity and equalities. It's still a problem with us in the way we think. Equity is not equality, access to care. As you can see from this picture, it's not about giving equal resources to everyone. It's about needs-driven, equitable system. So we should give who is needed. Vulnerable group need more than non-vulnerable group. So if you look at these pictures, if you give equal care to see what's going on in the park, you still have those vulnerable groups that can see nothing, because you have to be being equal services. We should move from equality to equity. And this is really not easy, but it is really the things that we should go after. So if you adopt the equity versus equality, I'm sure you will save time. And our research, even as presented by last presenter, should really go to the equitable research evidence rather than giving access to everyone. So this is the picture, give a message, how we address equity and build our health system. Next, please. So
Thank
now,
you, Dr. Sorry, Dr. Khaled, would you wrap up in any minute, please?
Yes. Okay. So why is rooted? There are many reasons, as you can see here. I'm not repeating. So economic status, conflict and war, weak primary care, fragmented health system, weak health system infrastructure. Next, please. So what can be done? I would like to say this is the one of the model that I proposed to all of us, that there is a CDC framework saying paving the road toward healthcare equality, that we need to know, address some policies, measurement program, and on top of this, we need to address infrastructure. Next, please. So at policy level, we know for a fact there are a lot of policy issues has been issued by WHO, universal coverage, adopting all policy and approach, strengthen primary care, looking for appropriate and affordable health insurance. Also now we have to look at EIP solutions and health innovation solution. Next, please. This is just elaboration how the problem look like in terms of equity and how can address it through universal health coverage horizontally and vertically. Next, please. So this is just also this give you a sense how the health universal coverage index based on World Bank data, our region is still suffering from low index in universal health coverage, and we need to do a lot of this. Next, please. So how to move forward? We have 3 strategies to move forward: prioritizing our investments in primary and preventive care, embedded equity in digital health, including EI, bringing health equity within the climate policy, and develop regional framework. We need a regional framework on equity. We cannot copy paste any framework from somewhere. Move next, please. So moving from national to regional action, this is my message. We need to think as a group now. It's not only national solution. We need to have regional action that can address the MENA region through our network. Next, please. So I will end up with this. This is my last message. Health equity is not a luxurious for stable times. It is a foundation for resilience in crisis. Thank you.
Thank you so much, really, Dr. Salimi. And as I mentioned to other colleagues, apologies for rushing. Just at least to allow 5 minutes for Q&A before hearing also from Dr. Mataria, who's going to give us at the end really the reflections and also take us from the kind of the diagnostic and of course with the innovation solution that all speakers mentioned to how to make it more into health system strengthening based on also what our dear panelists now just mentioned. Thanks so much. I would like to invite all panelists to be back on the stage, and I have a couple of questions. And apologies if I may reframe the questions a bit from the audience just to make it tailored to some speakers. And my first question is coming from a colleague asking really how do we see the issue of colonization in health and health inequity, and whether there is an opportunity to be free from colonization in health. I see maybe a potential respondent, and I would like to ask you all to have maybe a 30-second answer so we can go through a lot of questions. Professor Fouad, would you like to take us through, because you started discussing really the political economy of health. You worked a lot on political economy, on global political economy of health. Where do you see kind of colonization affecting or post-colonization, or so that's the question, please.
Well, thank you. I mean, in 30 seconds to answer about the issue of colonization and decolonization, it would be super challenging, but absolutely. I think I can see it recently that we people working in health, issues, public health, global health, that we are more and more start engaging in trying to answer the issue of big and hard question of politics, the role of politics in health, or the political determinants of health. And I think this is the beginning of start questioning the issue of colonization and decolonization in that term of how to plan our program, how to think about the others, and how to go really as a sort of a global, more than global is the others. Global is all of us. And I think that will bring the issue of locals or local communities, into the core of the global health. I'll stop here. I don't know if some of the colleagues to try to add. Sorry.
Yes, if any quick reflections from anyone, maybe.
I'd like to say the quick thing. I mean, when we talk of colonization in science and research, we usually think of, for example, high-income countries versus countries that have less resources, which there is plenty of that, and that's really important. I mean, sort of the issue of people who are based in high-income settings, and then they go do research on low-income settings, and then they go back. The capacity never stays there. So, I mean, that's a major issue. What I want to add to this, there is dimensions of that also within middle and low-income countries, inside the countries as well. So, for example, there are certain things in certain institutions that they dominate the spectrum of research within that country. The involvement of all the institutions is not there. So it's not just about, I mean, I second what Dr. Fouad said. I mean, going to the community level, absolutely, but also at the level of the way we engage different groups is really important. So it's an issue of making sure that the people who are closer to the topic are the most involved. And they are not just involved as collaborators, but they also lead it, they guide it, they prioritize.
Thank you so much, really. Thank you. I think there is a... Yes, please.
Yeah. I think this is a really important thing. The colonization is about how we define it. Actually, colonization in a way that our mindsets need to be really questions how we address our problems, and I see some problem is copy paste in terms of even research agenda. We need really to think what's really needed in our region, from within the region, in terms of the research priorities, in terms of policy even, because even if you look to the policymakers, they are driven by the somehow what was going in the community, or other way around, how the community will bring their voice to the policymakers. So the question is now how we really define colonization in a way within us to move forward what set our priority for ourselves. And even if you save the funding, we need the help from the globe, but it's not like a injection and go. It's about how we really sustain this kind of help to remain. And if you're going to help me for a moment and leave, I think it's not a help. It's just like an injection, give it to me, and then I'll go back to the pain. So I think colonization needs to be redefinition within our context rather than the dictionary definition of colonization. Thank you.
Thank you so much. And this is really touched upon another questions in the chat about really kind of the reduction on funding and how to within the reduction fundings. But as you said, even when funding is there, how to make it kind of the impact of any work can be sustainable. So thanks for addressing that. And also I can maybe merge this question of why we're still seeing inequities with another question in the chat, specifically talking about climate change. Which is not well settled in the agenda of policy makers, and kind of we're still scratching only the top of the iceberg. So and the question is to Dr. Al-Nsour, from the experience, your experience, how to really bring it to the top of, or to bring it to the agenda of policy makers who are just busy in our region to do many things. And it's also in line with what Professor Alsurimi mentioned on advocacy. So really, it's
if you allow me, I can see here, for example, from academic point of view, actually, we know that at the end of the day, equity is a political decision, as I said. It's about justice. And it's about values in the policymakers. But even in academia like us, we are professors in universities, we need also to look at the curriculum. You know, I'm teaching College of Medicine, Public Health, and Health Sciences. These concepts are not really rooted in the curriculum to raise awareness among future health workers to be in their practice provide equitable care. So the issue now, we know it's not only one solution, it's a long-term solution, but we have to start to diagnose the problems. I see curriculum is one the area is missing in our region. Is not accommodating this kind of new political related concept, like, for example, equity, efficiency, stability, political determinative health. All these are really something is strange for the health professionals. So if you want to create this kind of addressing inequity, we need really to go to the root cause of the problem and look at from multifaceted factors. You cannot fix one from one end. So it needs like a momentum from different perspectives. This is my humble answer to this.
Thank you so much. I have also a series of questions about science and information systems, so I know who to ask this question to. So Professor Rashidian, I think there is a question specifically about what you were trying to highlight as a priorities at the end, because some colleagues mentioned in the chat, how can science and information system be better leveraged to promote equity-driven coordination in politically in divided internal borders, kind of divided health systems across the MENA region. And also, I think I saw another question flagging what insights can we share from recent research on initiative that demonstrate the importance of investing in. So this is a different story. So I'll get back to that. But let's go to the first question. Sorry.
Yep. I mean, so these are, as I said, pertinent daily questions. It's not the questions, you can actually rephrase them and ask them about, for example, in a country that is not affected by emergency, but has different socioeconomic status in different parts of it. So in a way, these challenges exist in sort of many scenarios. Let me, before going directly to this, a quick note about when the funding for these areas for health in the global level has gone down. That's absolute challenge. It has caused a lot of challenges for everyone, including the WHO. But what I want to say, the challenge in our region is that most of the institutions do not have enough national resources from the national budget for addressing the priority research, training related to us. That's the thing. I mean, if I want to give a message, I mean, whatever happening at global level, we should try to solve it together. But addressing the national team from inside is important. So going back to the context of emergency, I mean, obviously those challenges are reality of life. People who have done research in this context, I mean, they are sort of aware of those. But I mean, let's look at the example of Lebanon. In the last few years, with the sort of different political challenges, the issue of migrations and immigrations and refugees coming from different countries. But at the same time, several institutions that generated extremely effective, informative research studies to do that. So there are ways to do that. The other question was about Yemen, for example, the issue of that when the political situation may not allow data sharing across the whole country, etc. So at WHO, obviously, I mean, we work with all groups trying to bring those together, make the linkages as possible, but national authorities make their own decision on those issues. At the same time, again, I go to the main message. When we are addressing these problems, usually the people who are involved in addressing the question, identifying the evidence, they are more prone to work with each other. We need to find the partners that are with us and then do it together. And these are the things that WHO can do a lot to work. Obviously, this network that we are all discussing within that context can be an opportunity to do that better. But also the other networks that, I mean, I refer to our Net2P network. I mean, that could be, could be platforms that can bring people together more effectively. So I'm going very quickly, I know, but I'm trying to save time for you for other questions.
Thank you. No, thank you really for the interesting question, answer and reflection. So I'll take one more question, which is really interesting because it's reflecting on community health systems. And maybe I would like to hear from Professor Fouad and Dr. Al-Nsour, because I think what colleagues in the chat, I'm trying to find the question, is trying to say, yeah, the question was, what insights can we share from recent research or initiatives that demonstrate the importance of investing in community health system as a foundation for addressing health inequity? So it's really kind of this discussion between top-down approaches and community participation. I know you worked a lot, Professor Fouad, on this with the REBO. So can you give us some insights, please?
Yeah, quickly. Actually, I'm sitting now in the Municipal Health Committee, which is a model of community health system. We're trying to do it here. So we work on two different projects under one umbrella. The one I'm here now, it's about learning site, how to, engage the community to have their representative in terms of health, and they have their strategy, they have their plan, they have their even, implementing program. And the other issue, the other project that's related also to is the CTC, or close to community. So we encourage also, different different components of the community, including, for example, the senior refugee informal health workers, to engage in the process of, health services and providers. And as you said, that when talking about, that sort of structure of health system, we always focus on the national health system, or sometimes maybe sub-national. We unfortunately ignore that sort of very local, or community health workers, and even as Dr. Surimi talking about, cross-border, health system maybe, or going to that global health system. So I think that there should be a conversation between all these issues of levels of health system, and with having the community health workers, as a sort of a milestone to build up on that. And that's linked perfectly with the universal health coverage, with the issue of the CDF. So it's all that issues of engaging, people to be a part of their health decision making. And I stop here. I think Awad actually is even better than us all to reflect on the issue of.
I'm leaving Dr. Mataria until the end because it's time, really. Thanks. I would like to thank you all panelists, really. So I'd like to allow at least 5 minutes to Dr. Mataria, because also in the chat, colleagues mentioning that we look at equity from the perspective of outcomes and outputs, where maybe the health system inputs are the problems. And they gave the example of human resources for health, the challenges, the shortages of our workforce in rural areas, in distal areas within the hub of the countries. So that's perfectly give us the opportunity to hear from you, Dr. Mataria, with your concluding remarks and reflections, please.
Well, thank you very much, Ibrahim. Thank you very much, all colleagues. I really enjoyed this session very, very much. when it was proposed to speak about equity, I said this is something deja vu. This is something that we have been always discussing and referring to. But the way the session has gone from starting from the networking aspect and then going into some of the foundational issues and the context, I think it was really an eye-opener for me, and I enjoyed it very, very much. So what I would try to do in the 5 minutes allocated to me, I'll just try to tease out 5 messages that I would like to share with you from the reflections that I have been listening to and the contributions of the colleagues also in the chat. I think my first message is that equity cannot be just left for the luck for it to happen. In the year 2000, our first World Health Report on health systems of WHO, I mean, equity has been identified as an intermediary objective. It was linked to access to services, but also it was linked to financial protection as an ultimate goal. Even then, after 25 years, if we look what is happening now globally, we estimate that there are 800 women who die every day from pregnancy or during childbirth. There are 77,000 or more people who die prematurely from NCDs. And there are around 14,000 children who die from preventable causes. And the burden is even higher in the countries of our region. I mean, Dr. Khaled has referred to universal health coverage, and he has shared some of the indicators related to universal health coverage. In our region, we estimate that 1 in every 8 individuals face financial hardship when they go and demand their health services. And with regard to the access, we are going slower and slower than other regions. Now, we used to be better than 2 other regions in the world. Now we are only higher in regard to access services than the African region. I mean, with all due respect to all parts of the world, but we have not been doing as much as good as other regions have been doing. So that's why we are regressing in our rank ordering compared to other regions of the world. So equity does not happen automatically, and COVID has really highlighted that in regard to how access to vaccine has been happening. So it should become an explicit goal. My second message that I could also tease from the presentation, and especially from the great information that was shared with us by Dr. Fouad, but also by Dr. Mohannad, is that context matter. And inequity in our region has been really shaped by the geopolitical context, in particular due to conflicts, to wars, to occupation. I am Palestinian myself. I was born and grew up under the conditions of occupation, and we know how occupation impacts on equity in the society. But also the consequences in terms of refugees, in terms of IDPs. And I liked very much a comment that was put in the chat that we should not also forget about the large number of migrants in the region who are not from, well, many of them are from within the region, but who migrate for labor, for work-related responsibilities, and especially in the Gulf Cooperation Council countries. So to look at also at equity between the host communities and the migrant population. I think Dr. Fouad shared with us some numbers about the refugees. I just want to leave you with 2 numbers that we use quite often. Our region is responsible for almost three-quarters, almost 75% of the refugees globally. So globally, we have 23.5 million refugees, and 3/4 of them originate from our region. Even when it comes to the IDPs, and I like very much the reference that I think the expression that Dr. Fouad used, the power borders rather than geographical borders, in relation to fragmented territories, he said, and governance. Half of the IDPs globally are within our region. We are talking about 6 million Palestinian refugees. We are talking about 6 million Syrian refugees who are mostly staying within the region. But IDPs also is a big challenge when we look at Sudan, when we look at Gaza, and the example that he has given, 1.9 million out of 2.2 million of the population of the Gaza Strip being IDPs. The third message that I could tease from the discussion is that the consequences are multifaceted, but Dr. Mohannad reminded us of the very important role of the community. And he shared the example of how we should be culturally sensitive. We should take the particularities of different communities. Repeatedly, it was mentioned, we cannot just copy-paste solutions. We have to generate solutions from within the context of our region. And he shared with us that 6 vulnerability groups where focus could happen if we want to really address the challenge of inequities in the region. The fourth message is about science. And I very much thank the colleagues who reacted to the presentation by Professor Rashidian. And I liked when he said that good science is key. And he shared with us the approach that we are taking in the region with regard to building back fairer. Nowadays, we talk about building back better, hoping that our health systems in countries that have been affected by emergencies would be rebuilt and rebuilt better than before. We want to bring an instrumental goal related to equity, to fairness in the health system. And for that matter, we need to rely on evidence. And he said that all countries can do better, and the evidence is there. And here comes the role of academia in generating that evidence in order to inform policies and supporting the policies. The fifth and last message, I want to reiterate, the wonderful presentation by Dr. Khaled, where he brought us back to the agenda of saying that equity matters, and which is what we started with, and the build back fairer. And when he emphasized that equity is not an option, it should be an explicit goal, and that this is in particular important in the fragile health systems in the region. I liked very much the linkage that he has made between equity and resilience. In WHO, we have been saying that we need to have equitable and resilient health systems for universal health coverage and health security. So framing these would be really very important. We look at UHC and health security as goals, while equity and resilience are prerequisite to advance these dual goals of the health system. And I cannot really conclude without reiterating the message that equity is political, and that equity is not about equality. It is about fairness, it's about justice, and it is about taking it as a regional initiative. And again, it is a message that has come, and it is, our regional director keeps saying that we should look at from the region to the region. So how we can work together as one region, one entity, in order to support one another, because if we don't do it for ourselves, no one else will be doing it for us. So how to come as one community, one society to support the different countries, especially those who are in most need. So again, thank you very much for giving me this opportunity, Dr. Ibrahim and Dr. Khaldi and Professor Trudie. That was really a delight to be with all of you and to listening to you all and to learn from the great work that is being done. Thank you.
Thank you, Dr. Mataria. And I don't have anything to say after your concluding remarks from the technical side. And as you said, I just want to thank all our panelists, and I apologize for running over time, but I found it a really very interesting moment to have all of you around the same table to discuss a very important topic for our region. So just to say that the recording will be available. Colleagues from the Global Health Network will share it. I would like to thank them, not just Dr. Khaled and my colleague from LSTM, Dr. Wissam Mansour, for that, but also Alex, Luis, Marina, and all the team for supporting that. And as Dr. Salim is doing, we'll have to take a photo quickly. It's just a screenshot. So even with Dr. Khaled, feel free to open your camera, and Alex, please, as well. So at least to have a moment. Apologies for colleagues who left.
Thank you, everyone.
Yeah, that's it. Okay, thank you so much, everyone, and thanks again for our
Thank you all.
colleagues.
Thanks a lot. Thank
Thanks,
you.
everyone. Bye-bye.
Thank you, guys. Bye. Take care.
Bye-bye.
Thank you.